to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, oh, my vagina.
Yeah.
And
Yes.
that's
all
not,
of the above.
That's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynaecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it. Welcome to today's episode entitled Women, Pain and Pleasure, a conversation with Dr Leila Frodsham. While we're diving into the world of psychosexual medicine, psychosexual disorders are far more common than many people realise, yet they're often surrounded by shame, silence and misunderstanding. For many women experiencing these conditions, getting help can be difficult, especially when the topic feels taboo or when healthcare providers may not fully understand what's going on. This episode is all about breaking that silence. We believe that knowledge is power, and by talking openly about these issues, we can make it easier for people to seek support, for friends and families to understand what their loved ones might be going through, and for everyone to feel more confident discussing sexual health.
And we're very excited to introduce Dr Leila Frodsham. So Leila is an obs and gynae consultant with a special interest in psychosexual medicine, currently working at Guy's and St Thomas's NHS Foundation Trust. She's one of a few consultant gynaecologists in the world with dual membership in both the RCOG, so Obs and Gynae, and IPM, the Institute of Psychosexual Medicine. She's widely published in subfertility, psychosexual medicine and gynaecology. She's passionate about holistic care for patients and mind-body medicine, and her special interests include vulvodynia, sexual pain disorders, subfertility and menopause, and many more things. We're looking forward to discussing all things psychosexual with Leila, so welcome and thank you for joining us.
Hi, nice to meet you all.
Fab. So I wonder if, to begin with, could you explain to us lay people what psychosexual medicine actually is and what sort of issues you typically cover?
So psychosexual medicine is a subspeciality of medicine where we focus on the doctor-patient or the practitioner-patient consultation and our relationship with patients. So we don't just do the physical medicine, and that is very much a part of what I do. So I can cover things like the impact of menopause physically, but I also do some work that's based on psychoanalytical and psychotherapeutic work within the consultation. So it's kind of taking that a step further than we are taught in medical school, just so that we can understand a little bit more about the psychology of what's going on behind a physical problem. And as you probably all know, mind-body medicine, it is very difficult to have a mental health condition without a physical implication of that. And we know that there's lots of things with mental health conditions like heart disease that give you much higher rates of physical illness, but vice versa. You are going through endometriosis, menopause, cancer care, you are very likely to have an impact on how you feel in yourself. And sex is one of the first things to go. Sex is a little bit like the cherry on top of a finished and iced cake. If the rest of the cake isn't there, it's just a cherry, it won't work. That makes sense.
Yeah, it's a
I
good
like
analogy.
it.
Yeah.
Good analogy. We like an analogy, don't we?
I do think it's you're saying you go with the physical and the mental aspects of it, and I think that's kind of one of the things that we get most complaints about, that people don't feel listened to, and that they feel like they're on a conveyor belt of next, and that's whether they're coming for any aspects of care. It's not just kind of niche kind of fertility or endometriosis. It's if you come in for an antenatal appointment, people just don't feel kind of listened to, and I think it's difficult to encompass that into care a lot of the time, because as you said, it's something that potentially we're not taught that much about, but a lot of times we know the pressures that everybody's under, and you are trying to kind of see and help as many people as possible, but actually by maybe not helping them properly and only half going that distance, then we're doing them a disservice.
So I think one of the things that I rapidly discovered, and I have to say that I started my training in psychosexual medicine when I was a very new registrar, so very early in my career, is that actually consultations are longer if you don't address the elephant in the room. So if someone is coming to see you, and it may be that they're in an antenatal clinic, I've seen lots and lots of people, and often it will present as tocophobia, which is morbid fear of childbirth and pregnancy, because we know that about 90% of them have a coexisting sexual problem, and that feeds into how they feel about delivery, be it cesarean or vaginal delivery. We know they've got much higher rates of postnatal, perinatal mental health issues. So 20% of the rate, double the rate of postnatal depression if you're tocophobic. Wow. But actually what I've found over my career, and I have worked as a jobbing consultant obstetrician and gynaecologist in a DGH, which, you know, I work in a teaching hospital now, there are big differences. We perhaps don't have the same complexity of patients, but we have many more patients in clinic. So my antenatal clinic would be about 35 patients, normally with a very junior resident doctor, somebody not at registrar level, and me. And most of my clinic was people with perinatal mental health problems, tocophobia, but psychosexual problems too. And actually, I was very fast. So I would always get to my theatre lists in the afternoon on time after my clinic, because if you're there listening, you're more likely to get to the nub of the problem. So a lot of people think, because I now run a tertiary clinic with 45-minute appointments, what luxury. They think that I just work in a zone where I sit and I go, well, how are you? You know, nice weather, whatever. I'm still working fast. And a lot of the people that I see have seen between 4 and 8 consultants before me.
Wow, that's a lot.
And they're often very, very unhappy. And I totally get that. And a lot of my first consultation will be listening. And I think that's a really vital part of what I do. Many people have had many investigations for physical problems where really we haven't addressed the actual problem for them. We haven't listened. And you're right, 83% of complaints in the NHS are about communication, and most of that is not listening.
Not ideal as a stat. I didn't know that that many people with tocophobia were related to kind of a sexual disorder situation.
I didn't know
what tocophobia was.
I didn't know it was a thing.
Well, we will cover. We'll go into
childbirth. That's quite recent data. I mean, I have to search far and wide for data in my area of expertise, and we still use data from the 1970s.
Wow.
We look at women's health. It's extraordinarily badly researched, but you then look at sex. In either sex, it's a complete misnomer to say that men have this wonderful service. What men get is Viagra, but very little discussion about what's going on behind their problem with erection. And Viagra is not a one-size-fits-all. It will help with erection if everything else is okay. If there's an underlying psychosexual problem, it often won't actually help them either. Doesn't help libido. I see a lot on social media of women understandably really frustrated and saying, men get such a good deal. They don't. I actually think it's possibly worse for men.
I didn't know it could be any worse, to be honest.
Yeah, it can.
Sex is seen very like surface level of it's just sex, and a lot of the time it's either it's just for pleasure or it's just to make a baby. But when you look further down, there's so much more that's involved in it.
And it's so key to your relationship as well.
I would say there's a huge amount of people with sexual problems who end up in physical clinics having operations, laparoscopy being one of the biggest ones. 85% of laparoscopies nationally are negative. And I've seen them done for vaginismus, where it's an issue of consummation, not an issue of necessarily pain. And so there's absolutely no need to do them. And they are a risky procedure. About 1 in 1,000 get visceral damage. So, and what I mean by visceral is organs in the belly, for those listeners that are not medical. And I think we've got a real problem, and it costs a huge amount of money to do all that physical work. when actually we're not really addressing the problem that someone's coming to see us about.
You're not going to find the cause of vaginismus by doing a laparoscopy. For our listeners, we've done an episode on diagnostic laparoscopies, but if anyone's not listened to that, it is an operation. You have a camera into your abdomen, into your tummy, and it comes with risks, as Leila said. So it's not something you should have lightly without understanding whether or not it will actually help you. But for something like vaginismus, it's not going to help you at all. So it's completely unnecessary.
I think the problem is it's that expectation setting, and I try and do a massive expectation setting if somebody's on a list for a laparoscopy, because a lot of times they've waited for years to get to that laparoscopy, and their whole life is surrounded by, but my life is going to get better once I've had the laparoscopy. And I think it's really difficult, because if they are woken up and you say, oh, it's great news, there is nothing there, I'm not saying that you're not in pain, but I can tell you that there's actually no physical pathology that we found, no physical condition that we found, I can understand why it's disappointing.
Yeah.
And we also need to take a really long, hard look at how it feels to be the person not just receiving the news that everything's okay when their life has been really affected by pain, but also the fact that they're recovering from an anaesthetic. And most people go, I cannot remember what was said. And the other thing that we do as gynaecologists is we often send the most junior member of the team to break the news. That isn't great for either side. I feel sorry for the resident that's there doing that, because they don't have the answers at their fingertips, but also for the person who's probably never met them before, doesn't necessarily have confidence in what they're saying. And what I find is that women who end up in that situation go to different trusts or different consultants, have another negative laparoscopy, and the cycle repeats. I think one of the worst ones I had 14 negative laparoscopies.
Oh my goodness.
Until they then had a bowel injury and had really significant pathology as a result. So I know in social media at the moment there's a huge amount, and I absolutely get this, of women saying, why are people not listening to me? Why am I not having a laparoscopy? I might have endometriosis. But it isn't always the best option. And if we can't give an answer from it, we need to think more broadly.
Just could not agree more. And this is a hymn sheet that I sing off a lot in the podcast setting, but also in a real world setting. And we've done a paper looking at our stats about the amount of negative laparoscopies that are done. I find it really difficult having these I don't find it difficult having the conversations, but I do have very detailed conversations about, what is the plan, because you've got pain, I'm not taking that away from you, but what is our plan following this laparoscopy if it is negative? Because I'm really worried about you. What are the next steps for you? And I think they're just kind of left to a lot of people, which is obviously rubbish. And then they bounce back. We've had these conversations so many times.
Or in having more procedures and having more complications from them, leading to more pain.
Definitely not an ideal situation.
It comes back to what you were saying, Leila, as well, about how it's about listening to the patient. So if you have the skills and the time, not always necessarily 4 to 5 minutes, but if you can address the elephant in the room at the beginning, you might then avoid the unnecessary loss of trust in the healthcare professionals and unnecessary investigations and potential complications of that.
It's a big thing.
Yeah. We should all be talking about sex a lot more than we are.
I think we need to reframe the time, don't we? Because the 5 minutes in consultation to explore what's going on versus hours for a patient to come into day surgery, pre-op assessment. And, if I'm being brutal and I'm thinking about the future of the NHS, the cost. So what is cost effective? And I can tell you that the service that I run is highly cost effective. We're very cheap. I shouldn't advertise that. We're in London. But we are very cheap. We're about £700 for a whole series of treatment. A laparoscopy, and if you start looking at theatre time, is thousands.
Wow.
And if you're left with someone who's really unhappy and not better, perhaps we should be thinking more about engaging with services like mine before we put patients on operating lists.
Agree. I've got nothing to add, because I'm like, agree.
That is spot on, yeah.
It's absolutely spot on.
So could you tell us a bit more about your training into psychosexual medicine, and how did it differ from training into, say, obs and gynae?
So I was already a fair way through my training. I was already working at a registrar level, although I'm sufficiently ancient to not have the sorts of training that you guys have. So it wasn't straight out of your house jobs or foundation and then into specialty training. For me, it was, we used to take a job a year effectively. And I saw somebody in a clinic who disclosed that they'd not had sex in their 50-year marriage. And this was on the back of seeing them about a simple gynae problem. And it was a real sort of hand on the door. I think I can trust you. I want to talk to you about something else.
Oh, wow.
And disclosed this to me and said, could I fix them before their wedding anniversary, which was 2 weeks hence. And I thought, oh my goodness, I've absolutely no idea what to do. And just sort of signposted them to the GP. Yeah. Because like most gynaecologists, I didn't know there were services available. Mm-hmm. And that person stayed with me because I felt that I'd not been a good doctor. I really felt that I wanted to help them. Mm-hmm. And I went to a teaching session for registrars, and I don't think I've ever been a particularly conventional gynaecologist, but everyone else in the room had a white coat on and had a stethoscope around their neck, and I sort of walked in sandals with toe rings and flares. And
we laughed.
Went, oh my goodness, who is this person? But the person who was leading the session, everyone was sat in a circle, went, come in, let's make space for you. And she simply asked this group of probably 20 or 30 gynaecologists, can you tell me about a patient who's mentioned a sexual problem to you? And literally everyone looked at the floor. But I was I don't fit in this circle. And I really want to talk about this woman. And because she's hugely psychologically aware as a trainer and a very experienced person. In fact, she was the wife of Marcus Filsey, who created Filsey clips. So all of us know about Filsey clips for sterilisation.
Well, the girls
so
there.
I'm like, if you have a...
And she...
Go on,
when you do a laparoscopic sterilisation, it's the clips that you put on somebody's tubes. They're called Filsey clips.
They're like little metal clips, yeah.
So anyway, she basically said to me, I think you've got someone to talk about. And I went, well, I do, but I'm not really sure it's a proper case, and I feel like I did really badly. And actually she grabbed me afterwards. Really no one else talked about a patient with a sexual problem, and said, the fact that someone has spoken to you after 50 years of struggling, I want you to join my training group because I think you've got natural ability. And nice. So I joined her training group, and it was the first place that I really felt that I fitted. Prior to that, I went to Leicester Medical School, where we had a whole week on sexual problems. And that included seminar training, and it was mandatory. There were a few people from my year who felt really embarrassed about talking about sex. And actually our lecturers said, you're the people who need to stay. Because if you're struggling to even sit in a session and a patient talks to you, you need to be able to deal with this. So when I started Obs and Gynae, I would go, but what's going on for this patient emotionally? I'm a bit worried that this person that's disclosed something to me, the time that their problem started was a really difficult time for them in their relationship, sometimes termination of pregnancy, some really huge thing. And basically, I then kind of went into my training and ended up as the chair of the training organisation at one point. I've been on the council for 11 years. I'm not on the council at the moment because I'm too busy. But I've done media and comms, organising all the national meetings and stuff as well.
Amazing.
And I train people myself now. And I can only hope to be as inspirational as my first trainer, who really was absolutely incredible. And it just didn't feel like training. So conventional Obs and Gynae is a lot of book work. IPM training is we bring a case that we've struggled with. It's all completely confidential. And we talk through it as a group. So I'll present what I've done, what I'm feeling. And often people will pick up things that I've completely missed. Like, actually, it feels a bit like this person's a bit angry. And it kind of feels like you're quite a different doctor in this consultation. Perhaps I'm teaching a little bit rather than sitting and listening. And that's possibly because it's easier for the person in front of me to get taught rather than think about the feelings. So, yeah, I mean, I think it's been absolutely incredible, and it's changed how I behave as a doctor in all settings. And probably also as a colleague, I'm much more emotionally aware of issues in teams as well.
Yeah, it must add a different layer to all of your consultations, having the ability to be a bit more, like you say, emotionally aware and possibly looking for the elephant in the room even when you're not doing a psychosexual consultation. I think...
And I would say the job satisfaction's enormous.
Yeah.
So when I alluded to the fact that people are less likely to have physical problems and go and see doctors after they've come to our clinic, I also get notes from patients saying, I've changed my job. I'm so much happier. Or they'll come to their last appointment with me and they literally look like a different person.
That's cool.
Sometimes when they first start coming, they're sort of tightly buttoned up, they're wearing grey clothes. And then as the time goes on, they start looking more like sexual beings, attractive, open, happier. So it's really, really lovely to see the change in patients. It gives you great job satisfaction to feel like you're doing a good job.
And amazing for them as their lives completely changing. Could you give us sort of an example just for our listeners to have an idea about what your typical week looks like in work? Because a lot of people won't be aware.
I am quite different because I've left pure obs and gynae. So I have 2 clinics a week. One is, I'm afraid, the dark evil side of private practice. I largely do that because my catchment area is London only. Yeah. So I do have patients from across the whole of the UK. I do some virtual consultations for people, say, in Scotland, where there's nobody local to them. I do have some international patients, but limited. I try not to do too much of that. Yeah. But then on a Thursday, I have my NHS clinic. I do a lot of the kind of management of the clinic behind the scenes. When we first opened in 2013, it was just me and my senior counsellor, and we're hoping to be a team of 8. I've recruited recently 2 new doctors, but we're hoping to recruit some more counsellors as well. We're also a big training organisation. Violetta, who's my senior counsellor, supervises COSRAT trainees, which is College for Sexual and Relationship Therapy. Yeah. So slightly different to the IPM. They don't focus on the physical. Yeah. So they're counsellors rather than doctors, although there are doctors and nurses who train with them. So she trains 2 people at once, and I'm training 12 people at the moment in my seminar group. Wow. But I also have people who come and work with us to train as well, because we're really big service at the moment.
It's amazing that you have so many people working there. I just think that that's lacking from a lot of clinics that we do. So for example, the endometriosis service a lot of the times will not have a counsellor or a psychology help alongside, and same for other chronic pain services, and you're just kind of like, you're missing, it doesn't help seeing a surgeon all the time, because that's not going to be the answer.
Yeah, and we'll delve a bit more into the conditions.
The endometriosis team in GSTT as well. So people, and we also have a mindfulness practitioner who's a consultant in elderly care. So our team in GSTT has a lot of extra members, including nutritionists, bowel surgeons, gastroenterologists. So it's a really big service, and I think there's leadership from doctors, but also our CNSs are really pivotal in leading the endometriosis service and deciding where we triage people to as well. So we do have a lot of psychologists in GSTT. So I think last count we had 140, and we have one in each department. They're both for patients, but also for staff as well. So post-pandemic, we have regular touch base with members of the wellbeing team.
That's
GSTT
like forward
is Guys and
thinking.
St Thomas's Trust.
That's like forward thinking though, because that's actually kind of not living in the here and now of let's do another laparoscopy. That's living in the let's think about what's going to happen trying to think about the future.
I think there's a reason that we're often top of the pops with the staff survey.
Yeah. I like it.
We'll all be relocating to London now. See ya.
So what we actually wanted to kind of chat to you more about, so for our listeners to understand a bit more about, how common are psychosexual disorders, and are they potentially recognised as often as they should be in healthcare? I feel like I know the answer to that, but let's have a chat through those.
So I would say if you look at NATSL, which is the National Study of Sexuality and Lifestyle, which interestingly was founded by my dad, so the apple doesn't fall far from the tree. you will see that about 40 to 50% of people have an acute sexual problem. And that can be something as benign as they would have liked to have had sex, but they had to get their kids in bed, or they came home late from work and felt too exhausted. Okay, so they're soft things, but perhaps something that is worrying them in the moment when they fill in the survey. But then if you dig a bit deeper to things that last more than 6 months and cause distress, it's 1 in 10. If you look at sexual pain disorders, and this is a population study, I think from 2014, the college did one where they contacted people and said, are you happy to do a survey? And it was 7.4% of women have sexual pain, which is really high. And if you look at NATSL and you look at that data, it's about a third of women at the beginning of their sex lives. And when I say women, I'm including trans, non-binary, but people who were assigned female at birth. It's about, and I would say there are peaks in some of those. Trans men, for example, if they're on testosterone therapy, are much more likely to have sexual pain. But you will look at about a third then, and then you get other peaks when people are having babies and people are going through some fertility problems, and then menopause. Now, the data from NATSL says over 50, but I see a lot of women who are mislabeled as a psychosexual, psychological problem with their first symptom as painful sex, which actually is a part of perimenopause. So I think it's always really important for women to be aware about genital syndrome and menopause, because it's so easy to treat. And actually what happens is if you don't treat it, and the treatments are so safe, that it then becomes psychosexual, because if you repeatedly try and have sex when it's painful, it becomes a big problem. So that's sexual pain. If you look at other things, there's very, very little evidence. So nobody really has clear data on vaginismus. Now, I include vaginismus into sexual pain. I sort of say there's a spectrum for sexual pain. So I don't like it when people refer vaginismus to me, because the majority do not have pure vaginismus. Pure vaginismus, primary, is where people may not even be able to consider attempting penetration because they feel very, very anxious about it. But at the other end of the scale, you have just pain. So they've perhaps been able to have sex before, but they've now got pain. The majority lie in the middle, in that they've got muscular spasm related to pain or related to something else. And it's very rare for there to be trauma with vaginismus. The majority of women that I see say, I was in gynae clinic and somebody ticked a box, were you sexually abused? Never do that as a healthcare professional. It is not a pro forma question. If you have been sexually abused, it can be deeply distressing, and you will probably be picking up some terrible memories for them, and that may make it really difficult for them. But you should ask them if anything has happened in the past that they think is a problem, and they then have the choice to go, maybe I don't want to talk about it. But actually, the majority go, I don't know why I've got this, because I don't have anything. And when the gynaecologist asked me, I thought, well, why is that me when I've got no problem, no trauma? And actually, there is some evidence it's often related to people who are more likely to be anxious personalities, perhaps perfectionists, perhaps feel a need to be in control because they're anxious. But the other end, the vulvodynia, there is often physical causes, and I get sent a lot of patients with, oh, well, it's obviously in their head because I've examined them and it's fine. But actually, when I sit and unpick it, there are other things going on. And they do very well, actually, quite quickly, often.
So we should just explain a bit what vulvodynia is, because
Yeah,
I
that was
guess
coming
you
up,
guys don't know, and a lot of our listeners won't be aware either.
So vulvodynia is basically pain in the vulva. That is exactly what it means. We're very bad as doctors, aren't we, at using terms that sound really clever and also terrifying. So that's why I much prefer people to go, you have a sexual pain disorder.
It's something
more
they can then
understandable.
identify with as well. Saying I've got vulvodynia is different to saying, well, I've got sexual pain, because that will mean more to the patient, and then they'll be able to identify with it as well.
So sexual pain you would use as an umbrella term, but then people would identify that they potentially have a condition under the umbrella of sexual pain.
Yeah, although I frequently say to people that I see, we may not give you a term, we may not give you a diagnosis, it's a very poorly researched area of medicine. And often we don't have all the answers, but I know that various treatments do help a lot of people. So it's worth trying them.
So
if you look at sorry.
I was just saying vulvodynia is pain in the vagina. And
Vulva.
Oh God,
Vulva.
sorry.
The classic trap.
Pain in the vagina is actually incredibly rare. You can have pain in the pelvis, so deep pain. Often I have a little hand thing. I like using my hands to explain things. So if that's the vulva with the lips as my fingers, that's the pelvic floor, and that's where the cervix is. When I say to women, where's your pain? The majority will point to this bit.
Oh, okay.
And that's a much better way to ask people about where their pain is. If you say deep, people will say that's deep. And it's very different in how we manage it.
So just something so simple, a visual explanation makes it easier to communicate.
So Leila's pointing to kind of the outside that people are pointing to rather than the inside.
So like your vaginal opening that you can see on the outside rather than the deeper.
It's about a centimetre or two in the pelvic floor.
Right, yeah.
But this is the most common bit. So if this is a vulva with the clitoris there and the bottom here, it's this bit here, what we call the posterior fourchette.
Yeah.
Goodness knows why it's named after a fork. But it's this bit here that most people will point to and go, that's where my pain is.
Yeah.
So sort of 6 o'clock for people that are not watching but listening, 6 o'clock at the bottom of the vagina.
6 o'clock.
Well,
6
we
p.m.
really imagine a clock face, although probably nowadays, it's more digital, isn't it? But anyway, that's a tangent.
So before I made my boff, I was trying to say that there are different conditions that we've mentioned. So vulvodynia, pain in the vulva, vaginismus. How would we describe that to people? Just because I want people to know exactly what these are.
So when I talk to people about vaginismus, they often feel great guilt that they can't relax. And they've often been told to drink wine. It does not generally help. You pretty much have to be near unconscious with alcohol use to have your pelvic floor relax.
Let's not encourage that.
No.
It is a subconscious thing that your pelvic floor contracts. And what I do is a lot of thinking about why it's contracting, but also looking at ways to reduce the contraction. So I say to women, it's a bit like if you put your hand on a hot plate and your body removes your hand, that's what your vagina is doing if there's pain. So your pelvic floor is contracting.
So I just wanted you to understand what it was, because I feel like we're using these words now under the umbrella or saying that some people will have this term, but I was just like, do you actually understand what vaginismus is? Because it's like a contraction and it's very different to other potential conditions.
And it's involuntary, isn't it? You can't control it. It happens without your control.
I mean, if you could control it, I wouldn't be busy.
Out of a job.
But I think getting to the bottom, just going back slightly, getting to the bottom of actually what the problem is. If somebody says and they're just like, I can't have sex, well, all these things that we've discussed, it could be any of these reasons / a lot of these reasons. And that's why it's really important to just be like, oh, okay, they can't have sex, we'll just refer them to someone else. It's
not
like,
ideal.
why can't they have sex? Is it because their husband can't have an erection? Is it because their partner can't have an erection? Is it because of dryness?
Really, really good point, Nicola. So I have had a number of women referred to me with vaginismus. And when I've sat with them, I've thought, this doesn't feel like vaginismus. I've gone to examine them. There is no vaginismus. And I've asked a little bit more about their partner, and it's their partner who is unable to penetrate. So it's so important. I talk about men as being the silent partner. We need to think more about what's going on with men in gynaecology.
Oh, and I wonder how long those patients have waited to see you as well, just from something so simple at the beginning, if someone had taken a slight bit more information.
I think it's because of fertility.
But it's okay in my clinic because I see guys. So I can see them anyway. So, if I was working purely in a gynae clinic, then it would be a bit more complicated. But we see men in our service too.
I think it's because from a fertility setting, you have people that get through and they've had various appointments, and it gets to a point where, I don't know, you need another semen analysis or you need something else, and they're like, do you know what? like the semen analysis, I've been avoiding that appointment because I actually can't ejaculate. And you're like, oh, okay, so you are...
Could have told us that sooner.
You are a lot down the line right now, and how has nobody worked this out that is the problem? So I think it's like thinking about all of the issues. So
having the full chat.
Yeah.
Out of
But
curiosity.
I would also say that most men can ejaculate through masturbation, and there is a bit of an issue with porn because that rewires men's brains, but they struggle with penetration.
So it's like a different...
Interesting.
I was just going to ask, do you ever have both partners of a couple in a consultation together?
I
or is it
do.
always separate?
It's not the IPM training way. We train people to see one person at a time. But as one of my patients said, I'm one of those people who looks at houses online because I'm interested in what's behind the door.
Oh, yeah.
But I will sometimes get partners in because it feels like the person that's in front of me is making progress, but it's not happening. And about a third of couples with sexual problems, their partner will develop a sexual problem as well.
Oh, right.
So it's really important to recognise that it takes two to tango. I do see single people. I see lots of single people. And in fact, I'm quite often joke that I'm tempted to set up a dating agency for people with sexual
matchmaker.
Because actually a lot of them really struggle to get into relationships because they just feel if sex doesn't work. And a lot of interaction on digital dating sites is about hookups. Certainly is in London. I don't know if it's the same across the country, but there's a lot of hookup action from many of the dating apps. So they just feel really frightened about that in case someone asks to have sex with them. Can we go back to vaginismus briefly? Because I think the treatment is not great.
Okay.
Across the country.
Tell.
So often what I find is when women get a diagnosis of vaginismus, and quite often it's wrong, they get given vaginal trainers, which we used to be able to prescribe, and we can still, but we've changed to ones that are meant for people with cancers who have radiotherapy that have got a broad tip. So if you have a real problem putting anything in your vagina, trying to do it with something that is basically blunt and impossible to get in is not very nice. They're hard plastic. I sort of say to women, well, if you're struggling with someone who you love putting anything in there, or you where you're in control and using your fingers, trainers are often even more of a challenge. And I often get this sort of sigh of relief that I've said it because they feel like a failure. The other thing is when you've got graded sizes, people may be able to put one in and then they look at the rest and think they're a failure. So they don't own that moment of jubilation that they've got something in. They just think, well, I'm not okay because I can't do the rest. But I see a huge number of women who can put trainers in but can't have sex because nobody's actually thought about what's going on behind. So they should only be used when they're being used as part of a therapeutic process. So if there's one thing from this podcast, I want people to stop prescribing trainers. And or physio. So it should be under the guidance of someone with emotional support because it's a traumatic thing to go through.
And that makes sense.
The programme Sex Education showed a woman using trainers and having orgasms with them. Nothing could be further from the truth. And I did write to the programme and say, I'm really unhappy about that representation. Because I get a lot of women who go, right, I've decided I've got vaginismus because I watch Sex Education. So they've done great stuff there. But I've been given trainers and I thought I would suddenly find them pleasurable. What's wrong with me? So that needs to be dispelled. The singular best treatment for vulvodynia and vaginismus is vibratory massage. You will reduce pain by 76% if you do that for a couple of minutes 5 or 6 times a week. So we as gynaecologists need to get better at talking about vibratory massage.
And is there an NHS vibrator that people prescribe? Or are you encouraging people to just do a bit of online shopping and see what they get?
Like, have you ever seen NHS devices?
Not sexy.
Imagine if you come with like a plug in the wall or something. like
the NHS branding on it.
Very large, very heavy, not even battery operated.
I knew
you were plugged into the wall.
Plugged.
Terrible.
What I would suggest is that people start with a pebble, and pebble vibrators. Oh, I've got one. Is this going to cause furore? is not the one I recommend. It's no longer in production, actually, but the shape is good. So this is basically like something you could put in the palm of your hand. I like the shape because it's got that nub in there. So if they sit on it with their clitoris here, this goes in the introitus, so it hits the spot where they get the pain and where the pelvic floor is. And they can literally sit on this with clothes on if they want, just while they're at their desk, perhaps not in an open plan office.
Maybe work from home.
Although I have to confess, I have used this for sciatica and nearly gave the receptionist a heart attack when they came into the
Brilliant.
I went out and said to the nurses, Miss Frodsham's buzzing. But it works really well.
Also, she's telling people it's for sciatica.
Yeah, it buzzed down the back of my tights in my back. But anyway, this is good. It's also soft and squishy, so it's not uncomfortable. And then they can move to using a bullet just inside. So like this, around there. And what that does is it means with the pebble that they're not putting anything in, so we take that pressure off them. But it's increasing blood supply, it's increasing arousal, different sensations, relaxing the pelvic floor. So it's a much kinder and nicer way to transition into sexual activity.
Also, it looks much less intimidating.
Yeah.
It's nice, it's a nice colour, it's got a little gold band on it.
Instead of like a box of plastic.
These are
like,
things that the patients will have to go away and buy themselves, aren't they? You're advising them based on...
They're cheap though.
Yeah.
They're cheap. I mean, they're like 10 to 20 quid.
Yeah, fine. Okay.
And if they work...
It's worth it. Oh, no, I'm with
yeah.
you. Yeah. Just thinking how, like, you know, this is clearly a very effective treatment for a very common condition. And wouldn't it be great if then, for people who can't afford even £10, £20, the NHS would make this available?
So I don't want to advertise particular shops, but there are shops that sell things for £1.
Right.
And you can buy bullet vibrators in there.
So, okay, it's more accessible then. That's good.
You looked really excited at that, Alison.
I love a pound shop, and I was
She's like,
thinking,
can you send me the link?
I was thinking, obviously in Liverpool we have Home Bargains, and I spend a lot of time in Home Bargains, so I was like, I wonder if this is the one she
You're on the wrong aisle.
Okay, so was that everything you wanted to mention about vaginismus before we...
Yeah, I mean, I think that's the one real kind of take-home thing is think about how someone's going to transition into sex. The other thing I do is I get them to use coconut oil because it's edible. So if we prescribe things, a lot of the women that I see have got vulvitis, skin condition. They often say they've got eczema elsewhere as well.
Yeah.
And if we prescribe a cream, it's got loads of ingredients. It's a bit like ultra-processed food. You look at the ingredients when we prescribe emollients, there's loads of things in there and a lot of people are sensitive to them. So I say coconut oil, which you can now get through one of the branded lubricant companies. Say which one, but it's one that a lot of gynaecologists use. And basically, so it's very healthy and safe for skin. It's actually good for candida, and it's good for bacterial infections too. But it's edible. So people then don't have to go, oh gosh, I'm going to just wipe off this cream that the doctor's given me before we can do anything sexual. So we need to think about the transition into sex for people rather than just being therapeutic.
Yeah, that makes sense.
Can I ask for people that would be even worried to kind of come, even you've said that people would come and get a diagnosis potentially and you would advise these treatments, but taking it back a step, so when they have got an appointment with yourself but actually they're worried to come and see you because they're kind of like, I don't know what she's going to do when I go. What happens when they come to an appointment with you? Obviously you have a discussion with them, and then from an examination point of view you've kind of said, and I've examined them and they've not got vaginismus, but what examination would you routinely do on people?
So I would say that I do different examinations to most gynaecologists, because I very much like the people that I'm seeing to feel very in control of what's going on. And I'm not saying gynaecologists don't do that, but I think we often have a kind of set regime. And we often go to put a speculum in first, whereas the people I'm seeing are in pain. And I would implore that all gynaecologists, unless you're doing smears where maybe you don't want to have lubricant everywhere and disturbing the cytology, do a gentle digital examination using a finger before they move to a speculum. Because speculums, even if you're somebody who's got children, you don't have sexual pain, they're not very comfortable. And actually, if you set things up that someone doesn't feel in control and they feel uncomfortable, it's not helpful. So I do have some people that will get on the couch in the first consultation with their clothes on, knowing that I'm not going to examine, so they feel how it is to be on the couch.
Yeah.
I think all gynaecologists should sit on their couches, see how it feels. I've put male colleagues on couches in lithotomy, and they have come out of that and gone, oh my goodness, I really had no idea how vulnerable you feel in that situation. It's a really useful thing to do. So I very much get people to be in control. And if they don't feel they can progress, it's fine. We'll just move to the next consultation. But really what I do is much more look at the vulva, just stretch the skin very slightly there at the back where most of the pain is. Because a lot of the people that I see, eczema doesn't look the same on a vulva. Because it's moist skin, so you don't get flaking. What they often have is tiny little fissures, a bit like when you've got chapped lips. And they often will say to you, it's like getting a paper cut. And maybe I get a tiny bit of fresh blood when I try and have sex. That is probably one of the most common things I see. And that responds fantastically well to using low allergen coconut oil. I don't ever let them use soaps or shower gels or feminine washes. And I change them from using pads that they get over the counter with gel in. And in fact, at the moment, I'm doing a petition with Helen Lynn and Karen Joash to the Houses of Parliament. We're putting a letter out to all gynaecologists to sign to say that we have concerns about the gels that are in pads and how that's causing problems with women's skin. So that's absolutely imperative that you stop that. So I get them to use things that have got bamboo or cotton, no gel. They're a bit more expensive, so often people find it's easier to use period pants. Using low allergen washing powders, so things that are not perfumed, non-biological as well. And sometimes toilet paper. There seems to be quite an explosion of scented loo paper.
I see that all over TikTok.
I saw some in Lidl.
Oh.
Not just lately. I love Lidl. But
I mean, why?
It's changing. I've actually had one or two patients who've gone away for the weekend and they've started carrying their own loo paper because they've gone, I was absolutely great and I was in this hotel and the loo paper is just like I sat all night with a swollen vulva in agony because they're sensitive to it. So I think always think in a similar vein to what you're putting on your vulva as to what you would put in your mouth. I'm not suggesting you put a Twix in your vulva.
Each to their own. We don't endorse that.
But all of that is great advice for people without vulval conditions or sexual pain disorders. Like if anyone with a vulva is listening, listen to that advice from Leila and you might prevent yourself getting, well, you definitely will prevent getting any vulval pain problems.
So I do have an article in The Guardian which is called How to Care for Your Vulva if you Google.
Love it.
I like it.
We'll put a link to that in the
easier than writing a leaflet for the NHS.
And do you speak to people who have orgasm dysfunction?
Yeah, definitely. It is less common. Do I think that it's because it's less common as a phenomena? Who knows? I think it's much more difficult to talk to people about. When I'm teaching, I will often say to the group of people in front of me, do people talk to you about sex? And most people will put their hands up as gynecologists, not all. And that's to do with how approachable we are. And then I'll say, do people talk to you about painful sex? And a similar number put their hands up. And then I say, do people talk to you about pleasure of sex? And I'll maybe get 2 in an audience of 100. And actually, I think that says a huge amount. So my other take-home message from today is, as a gynecologist, don't go, is sex painful? Because there's so much more about sex than just pain. And often people who have had painful sex and are no longer having sex, or their partner's got difficulties, so they're not having sex, so they can't tell you it's painful because they're not doing it. But say, how's sex? So less words, more opportunity for people to open up.
It's a nice open question.
Nice and easy, And when you do see people with, you see men and women in your clinic, but if we're focusing on women specifically, what are the kind of most common causes of orgasm dysfunction that you see, or is it very varied?
I mean, it's like anything. I would say every person that I see is unique, and I will treat them as a unique person. And even if I meet someone who is pretty much the same demographic as me, and in a heterosexual relationship, I cannot make assumptions about what they like during sex.
Yeah.
So it's all very, very personal. A lot of difficulty with orgasm is related to control, which is similar to people with vaginismus, and there is a fair bit of crossover. Although a lot of women with vaginismus have a really great non-penetrative sex life, and people often don't talk about that. Some of my patients are able to have anal intercourse, but they cannot have vaginal. So we should never make assumptions about anyone.
No.
But I would say it's often about losing control. Sometimes it's about some childhood stuff. If people are brought up in an area where they don't feel in control, that can really affect how they feel about sex. Because being able to experience pleasure during sex is ultimate loss of control, isn't it?
Yeah.
You're really handing over control to somebody else if it's not solo sex.
And you mentioned as well that you see patients relating to sex around menopause. So we had a guest on not too long ago, but Dr. Paula Briggs, who covered quite a lot about GSM, so genitourinary syndrome of menopause, where women will often get vaginal dryness, and that can cause pain and prevent them wanting to have sex. Because it's so common, I guess you must see quite a lot of women with that condition in your clinics. And
I do. I think we are profoundly misogynistic when we manage genital syndrome of menopause. And I know that's a really big statement, but hear me.
Yeah.
What we do is we treat vaginas and we assume that women have sexual pleasure from penis and vagina sex.
Yeah.
Whereas sex takes many different forms, and anyone who's interested in female sexuality should read Sheer Heights, Analysis of Female Sexuality. That is a super old book. I read it as a teenager, and it was old then. It's from the 70s. But it is probably the best analysis of female sexuality going, and it's still quoted by a lot of sex therapists. So only about 20 to 30% of women will have will have orgasm from penetration. The majority, it is from stimulation of the vulva. And yet these poor women with genital syndrome of menopause get given vaginal estrogens, and they still have their terrible symptoms, be they sexual or not, because their vulva is what's rubbing against their clothing. It's not their vagina. So they may be able to have penetrative sex, but they have very little pleasure, because at menopause, the clitoris and the vulva shrinks. And I'm really cheered, having worked in menopause for 30 years, that I've now got women specifically coming to see me about that because they feel safe to talk about it.
Yeah.
Whereas it was something that people just didn't talk about until probably the last 10 years. And I think that's social media. So we need to estrogenize the vulva as well. And that can then help with sexual sensitivity, and definitely will. Because if sex doesn't feel great, you're not going to want to have it, are you?
No. And why would you? Why should you?
So it's vastly common, and we really should be encouraging women to use both vaginal and vulval estrogens.
And I think talking about sex, it's like the end point in a sense, because if someone's just got pain when they've got their knickers on, or they've
just
got,
when they're dressed,
like sex is the last thing you want to do. You need to get the kind of like day-to-day stuff sorted, so you can go to work, be able to sit down,
Going to the
have
toilet.
pleasure with seeing people, and like
Yeah. I really liked your analogy at the beginning about how sex is
And we
the
also
cherry on the
have
cake.
a problem with people making money. People make money out of sexual problems in menopause. There is a massive menopause pound industry now. And that includes people selling sex toys. Now, as you were saying, Nicola, if you are too sore, even something, your pants rubbing against you, you're not going to want to use a vibrator.
No.
Although I would encourage women to use a pebble vibrator regularly because it increases blood flow. But there's a huge industry in it. And a lot of the mainstream stuff that's been out there recently about menopause has not really properly looked at sex. And that upsets me. You can tell I'm sort of that angry from Tunbridge Wells person, aren't I? I've written it and said, please think about women and sex toys and not making money. But I haven't had anyone bite on that yet. But yeah, we do have a real problem with how we're managing sex and menopause at the moment. And there's also this just use testosterone. And as you said, if your vulva doesn't feel right, you're not going to want to have sex, even if we give you a systemic testosterone.
There's that. And also, if you've not had sex for 20 years because it's not where you want to be in life and you don't want that cherry on the top because that's actually not what you want in life, having some testosterone 20 years down the line is also not going to make you suddenly want to have sex. And I think those conversations are quite difficult because actually, according to a lot of social media, what you need to do is hit perimenopause and go on estrogen, testosterone, and progesterone is actually kind of at the bottom of the list, and that's why you end up people in the PMB clinic, the postmenopausal bleeding clinic, and it's people have just got it the wrong way. It's not going to cure everything in your life. It's not been proven to do that.
There are people who are promoting progesterone only HRT at the moment.
Yeah.
Which is not going to control your symptoms.
There's a huge amount of misinformation on social media, and it's a big problem. As we all know, progesterone is actually the risky part of HRT, especially the synthetic ones. It's more likely to give you breast cancer. The others don't appear to anywhere near the same degree. So actually just giving progesterone, which is often the bit that people omit because it makes them feel miserable, doesn't make a huge amount of sense. That being said, I'm a big proponent of listen to women and actually tailor their HRT to what suits them.
Oh, yeah.
It's a lot of, so what symptoms do you actually have?
So,
Shall we think about how we can help you with those symptoms? Because if you're taking systemic HRT, but actually all your symptoms are vulvovaginal symptoms, what are we doing?
Can we do something else?
Let's...
Fits with our title for our menopause one size does not fit all.
Yeah, it does actually, you're quite right.
So you described sex as the cherry on the cake, which I think is a really nice analogy, but sex is often kind of integral to your relationship, regardless of the type of sex that is, but intimacy is very integral to that and often very important to people's identity as well. So the patients that you see, it's quite a broad question really, but what kind of impact do you see the sexual dysfunction having on their lives? Do they come forward with that information? Is it quite extreme?
So one of the problems I've got at the moment is, and we're trying to do some work on that in South East London, and I'd love to do more on this nationally and have been involved at a national level, is, for example, if we look at women with breast cancer where they have been told that they mustn't have HRT in any form, they will perhaps speak to their breast cancer team and say, I'm having great difficulties with sex. And they may not ever get referred. Perhaps people don't know about our services. Certainly don't feel confident talking about it. And so they end up on a sort of self-discovery mission and eventually end up in my clinic, but maybe 5 to 10 years after their diagnosis and treatment. And normally their relationship is completely in tatters or totally gone.
Oh dear.
And they're often really despondent that anything can be done at all. And actually, if a lot of their symptoms are related to vulvovaginal atrophy, genital syndrome of menopause, a lot of the problems are irreversible by the time you get to 10 years. So you can create some benefit, but a lot of it is no better. So I think we've got a real problem with people actually accessing services at the moment. It is a real problem. We need to look at how we can improve that. I did a parliamentary review, and would you believe the deadline for submission was the 4th of July, which, if you remember, was election day. So I've never had a response on that. If anyone from government's listening, it'd be really helpful if you could
just get back to me.
There's conditions in there that there's huge cost savings from services like mine. There's vast swathes of services like mine that have been shut in London, but also across the country.
So we know that everybody's not going to get access to you, which is a shame, but we have to be, we have to be realistic about this. So what can what can patients say to their medical practitioner that they see? What can medical practitioners do in the first instance? Because we know that there is not capacity for somebody to see like yourself. So
there are 700 people who are trained with the IPM in the UK, and there are many more on top of that who are trained with COSRAC. So first thing I'd do is I'd look at the 2 websites for people who are specialists in your region. So that's IPM and COSRAT, and they're both .org.uk.
We can put links.
So that's the first thing.
Yeah.
The second thing is I would refer to the PLICIT model, which is an academic model of managing sexual problems, which is an inverted triangle. So at the top is somebody has managed to say to their practitioner, any practitioner, could be that they're meeting an HCA on the ward when they've come in for surgery, just saying, I've got a sexual problem. And in fact, my HCA, who used to be in my clinic, was the master of
Love that.
great with patients. She's retired now, sadly. And a patient would be seeing some professor of something and go, I've got a bit of a problem with sex. And she would then come to me and say, do you think you could see this patient? I'd be like, yeah, absolutely. So she'd then go back to the professor and go, can you refer to Leila, please? So it can be anyone. But if you do that, you will help about 40 to 50% of people with a sexual problem, just allowing them to disclose and talk to you. If you then add in a little bit of advice, just general advice, which might be, oh, well, you could try some vibratory massage, or you could try some topical vulval and vaginal estrogen, then you're well over half. You're probably more like 70%. If you then signpost to a specialist service and say, here's some guided advice, then the majority, over 90%, will be better. So the people who I should be seeing are under 10%.
Yeah. Wow.
So really, it doesn't need to be anyone who's specialist, but I would encourage all people who work in healthcare to think about doing an introductory term for the IPM, which is a 12-hour course. It is a bargain. It's about 300 quid for 12 hours. I think you don't get much now for that.
You don't.
That's a good deal.
Where you can come and learn a bit about helping people with sexual problems and also talk about some cases that you've seen, so you get a bit of an idea about what we do. And then you might want to go on to further training. If you do, it's 2 years of 36 hours a year that we tend to try and do when you're not working. So if you are working as a gynaecologist and you're working weekends and whatever, we try and fit it in so that it works well for you early evenings, Saturdays, whenever. And then you can do your diploma exam, and then a further 2 years you can do membership. And once you've done membership, you can run a service like mine and take referrals. But I would say whatever you can do to make yourself feel more confident, you'll really be helping people.
I think it's really important that as well to highlight that it doesn't come into obs and gynae training very much. It's a very small amount that we would be expected to know to pass our exams. So people like yourself who have decided to train in psychosexual medicine have done that completely on their own back. So it's extra hours of training. So you are clearly very passionate about it, which means that you will get a very good level of service when you get to see someone with the dual training. But why there's so few people in the country, because it's a lot of extra work.
Well, I was actively discouraged from training, and I worked for people who told me not to train, and that while I was working for them, I shouldn't.
Oh my goodness.
Wow.
So it's really interesting. I mean, I think people think they're going to see a gynaecologist to talk about sexual problems. If you look at the paper, Tomorrow's Specialist, written by Wendy Reed, it's in the top 3 of things that women want from a gynaecologist. And yet we are absolutely inadequate at offering it.
Yeah.
One really good piece of news is that the medical licensing assessment by the GMC includes sexual problems, and that is the first time it's been mandated for medical students. So we are going to have a generation, particularly if they're King's graduates and various other med schools where we've infiltrated. You will find I get loads of students who go, actually, I want to do this as a job, and the practice of what we do is useful for all areas of medicine, not just sexual problems.
We should probably talk a bit about GPs as well, because it's not often a gynaecologist that a woman will see first with a potential sexual pain problem or something else. And I know that you've done quite a lot of work with training GPs in London, I think, about psychosexual disorders. How did that kind of training go? Did it improve the patient service that they get?
I mean, the first thing I would say is that GPs are trained in a very different way to gynaecologists. They are far better at thinking about doctor-patient relationships.
Right.
So they are trained to be excellent communicators. And they're a really prime example of excellent communication reducing consultation time, because look, they only have 8 minutes and they often have to cover a huge amount of ground and do all their admin as well. So they really are up against the clock. And I know We're not a huge amount better. I mean, a lot of my follow-ups were 10 minutes when I was working in pure gynae, but they're really good at getting to the nubbin of the problem. So they start off at a bit of an advantage. And I do train GPs from all over the place. Actually, I've trained GPs from further places when we've done virtual learning, including international people. And often they feel quite worried about taking on something different and thinking it's going to take a long time. But I'm training a couple of GPs at the moment who are absolutely incredible. And they really have picked it up so quickly, and they've all reflected that it's totally changed their practice.
I love that.
Wow.
And they're seeing sexual problems everywhere now because they're more approachable to talking about sex. So I think GP is a wonderful area to pick this up. And often the people that I train will arrange to see people at the end of surgery so that they've got a bit of extra time if they feel it's more complex.
I think we've done kind of a really lovely full cycle with regards to coming back to communication is key. And it's kind of gone through the whole of the episode in like a little stream running through. I think we've definitely kind of understood that. Got it. Communication, and it doesn't have to take a long time, which I suppose is the other thing. So thank you for that. We have got a few questions that are like kind of quick fire questions that we would like to go through, if that's okay, which people can kind of come in on, but they are kind of for you, if that's all right, Leila. So go ahead.
Go first, Elle?
Yeah, absolutely. So, can sexual pain appear suddenly even if I've never had issues before?
Yeah, absolutely. So the classic is something very traumatic. An example is a diagnosis of chlamydia within a stable relationship. That is like throwing a bomb into your relationship, isn't it? Because you've got so many questions about what is going on. Chlamydia can be there dormant in the cervix. So it may be that it's picked up at fertility investigations, but it's been there for ages.
Oh, wow.
So that's the first thing. Thrush, candida that's poorly treated or not treated. None of us as doctors should give women antibiotics without giving them something for thrush. And people will continue to have sex. Perhaps they've had swabs that have come back negative, but you can have candida there. You can have resistant strains of candida as well. And when you start having sex when it's painful, your vagina contracts like a hand on a hot plate. So that's another one. But yeah, it can.
Wow. Another question is, do I need a partner to work on overcoming sort of sexual pain, or can you do it solo?
Not at all. Absolutely not at all. So I can't give you the exact figure of how many people we see in the service who are single, but I would say it's at least a third.
Wow. And it doesn't look like the Pebble vibrator needs two people involved, so very much something one person can do.
And as we discussed it's interesting because you potentially aren't going to even pursue trying to get with somebody if that's like in your head already. Like
if that's the barrier to it.
It's like when do you tell them, hi, I'm Nick and I've got, like it's like that, like,
Well, and that is a really valid concern for a lot of the people that I see. When do I tell someone that I have a problem with sex?
Do I need to put it on my Hinge profile?
I see both men and women and trans and non-binary. It is the same for everyone. It is not just women that are frightened to talk about this, who will really torture themselves with, how do I bring this up? And, I quite often quote figures of how common things are, and that actually there is quite a decent chance that person they're with actually also feels really anxious about sex. And even if you don't have identified pathology, people generally feel a bit anxious about having sex.
I feel like that would be normal with somebody new.
Another one, this sounds like something someone would come to you for and really actually have a proper conversation about, but someone's put, why don't I feel desire anymore even though I love my partner?
So I would say it's important to kind of unpick this a bit. I think communication is really key, and quite often what happens in long-term relationships is we get into patterns of routine, and that can become really unsexy. So I quite often advocate that people do erotic mindfulness. So that's where you listen to erotic stories and relax while you're doing it. Just thinking about sex a little bit more, because often when sex becomes a problem, we avoid it. There's a really, really fantastic film called Hope Springs with Meryl Streep that I advocate almost all my patients watching, and also for people who are thinking about training or understanding sexual problems better. It's handled incredibly sensibly, and sensitively, which is a real rarity in Hollywood films about sexual problems. But it's also quite upbeat. I think a lot of people, when I go, watch a film about someone with a sexual problem for 10 years, they think, enough, I have this myself, I do not need to see it.
I was going to say, I'm a big fan of Meryl Streep, so I'll be watching
it. Opens conversations, because it shows their mundane life and how they avoid sex. And then it starts them going, actually, do you know what? Maybe I don't need to go to the gym every single night. Maybe I'm avoiding sex here. So it's a lot of getting sex back on the map, a lot of communication. It's very rarely something physical, with the exception of menopause, or where there's a sexual pain like endometriosis as well. So a lot of people kind of come to me and go, can I have a magic pill? And I do joke and say, if I had the magic pill, I would not be sat in an NHS clinic, I'd be on a yacht. There isn't a magic pill or libido. Whatever you might find, I noticed that someone is encouraging use of a cream that has the same effect as Viagra for women at the moment.
Oh, I've not seen that.
I do use Viagra in women if they've got arousal disorders or if they've got genital syndrome of menopause that's resistant to other treatments because it increases blood flow. But that doesn't give you libido. No. Having engorgement does not give you libido.
No.
And in like men with erectile problems, if they have a psychosexual problem, it's unlikely to work.
Yeah. So the next question is, how do I explain having sexual pain to a partner without, feeling that probably inherent embarrassment?
There's a really fantastic paper, sorry, it all sounds very academic, doesn't it, by Debbie Lovell, which is, I'm so pleased you asked, which she actually came and had a chat with me in clinic and said, she's a psychologist, she's brilliant, said, I'd like to do a study looking at men's experiences of partners with sexual pain. Okay. And I actually recommend this paper to a lot of couples because as much as people say they don't feel rejected, they often do.
Yeah.
So it's really, really important that those conversations are open. And actually, vast majority of your partners will know you're in pain. It's very difficult to fake I'm not in pain. And actually, it's often a relief for them to hear that you're in pain. Not in a bad way, if you get what I'm saying. Because they think, oh, it's not me. It's not me. They're in pain.
And we'll move on to some myths and facts as well. So we've got sexual pain just means you're not relaxed.
No.
I think definitely not true.
You're
likely to be relaxed because it's painful.
Yes.
But it is not that lack of relaxation causes pain.
That sounds as easy as you just get pregnant if you relax a bit.
Yeah,
just start thinking about it.
And you get pregnant. We'll put that in the same bin as that.
Yeah.
Somebody posted something on a doctor page I'm on the other day saying that women who were stressed were more likely to have children with autism.
Oh, for God's sake.
Which really upset me because there is a huge amount of guilt, particularly put on women, that if they're more relaxed, everything will be fine. And that's not just in sexual problems. There's a huge amount of mythology about autism. One could say that people who are autistic themselves have a genetic propensity to have a child with autism. And because of the autism, they are more likely to be anxious, aren't they?
Yeah.
Rather than actually thinking it's
very
their
unfair
fault.
Relax.
Just makes people feel shit.
Just, I have people that actually say, like, what kind of level of stress do you think is okay? And I'm like, I didn't know that we put stress in levels. Like,
can we categorise that?
How you categorise?
Yeah, just another extremely unhelpful thing to hear. When you have pain during sex, just trying to relax is not going to make you feel better, but then believing that it will puts you in more stress.
You're like,
you aren't relaxed.
You're like a board. Like,
There's nothing more stressful than being told to relax.
Yeah,
literally.
True.
Another one which is interesting. If you love your partner, you should always want to have sex with them.
Totally.
Always.
I mean, like we've said already, about 50% of people will feel that they've got a difficulty with sex, probably because of life in general.
Yeah.
So, you know, nobody, even somebody who is 100% sexually functioning well, will want to have sex all the time, because life gets in the way.
Yeah.
And I see a lot of people who go, actually, I'm all right with sex when I'm on holiday. And I do quite often say to them, no job is worth spending 30 years of your life or even more being so miserable that you can't have a relationship in the way you want to.
Yeah.
Yeah, that's really good advice.
That's just great life advice, isn't it? Don't do it if it makes you miserable.
I saw a video the other day and it was someone saying, oh, like when you feel really worried about certain things, think of this. And it was a video of them, and then it zoomed out to the whole earth, and it was like basically saying the so
You're
like,
insignificant.
no, I didn't take it as that at all. I thought it was really good. I thought it meant that like don't overthink everything.
Yeah,
Like,
there's a bigger picture.
Yeah, zooming out, I guess.
Yeah.
I think the bigger picture is useful. Definitely.
yeah, maybe we take the video in 2 different ways. And a final myth, that vulvodynia is caused by poor hygiene and infections.
So, I do have women with vulvodynia who are advised by gynecologists never to touch their vulva or vagina with their fingers,
Oh, right.
Why?
to wash before sex and after sex, to ensure that their partner has washed before they put their penis in. Actually, vulvas and vaginas benefit from a good microbiome. So the advice I give is, please don't use loads of washes. Please don't add loads of chemicals. Please don't remove all your pubic hair. And if you must remove your pubic hair, because there's a lot of societal pressure, then clip or use IPL or laser. I prefer IPL. Let me tell you, there are bars in London now where you can get hair transplants from your head to your vulva because people have had laser. And you can also get the equivalent of fake eyelashes and fake eyebrows put on your vulva, because women are now going, oh my goodness, I've removed all my hair and it's now trendy to have a bush.
I actually
this like
did see there's like
The bush
underwear
thong.
with real
Skims,
human
yeah.
Skims,
Yeah, that's Kim.
to put on.
Skimped
Yeah.
underwear has now got pubes on.
They've got the nipple
So
bra
it is.
and the pubes.
Yeah.
Yeah.
Oh my god.
And you can get
crazy.
nipple piercing bras as well.
That is absolutely
It's crazy, isn't it?
I feel like people will regret having like full laser of the vulva, and I think that's because when you see people and they're older, you're kind of like, I don't know, it just feels very
Trends change,
exposed,
don't they?
and
Like in
things
the
change,
70s,
yeah.
a full bush was all the rage, and then you come to like the noughties and it's nothing at all,
Yeah.
and then it'll just come
Why
right back
is it
to.
though? Have you ever thought about that? There's a really
Go on.
fascinating documentary on Channel 4
Tell us.
called How to Regrow Your Bush. The reason that women are removing their vulval hair started in the porn industry so that people could see the penis going in the vagina better. So yet again, it's another control of women. And actually, it is causing problems. I see more women with vulvodynia where they are regularly shaving.
Yeah.
And it's a bit like when we talk to women about not shaving before we do gynae surgery. We know that wound infection rates are much higher because we've destroyed the microbiome. We need to think about the vulva in the same way.
Yeah.
So you can clip, you can do IPL, but don't wax, don't use creams. Think about whether, and shave, think about whether or not you do laser, because you might regret it.
Yeah.
There's no going back on it.
My mind is blown by those eyelash extensions for down there, though. Like, I can't get that image out of my head.
Crazy.
I think we're done.
Yeah,
that was amazing.
That was really good. So I feel like we've covered like so many different topics, and I love the fact that like a lot of the stuff is just things that we have kind of touched on before, but you've gone into way more detail, but also you've kind of really hammered it home about this communication and making sure that we're treating people for what they've come with, not what we think they've come with, or not what their referral says they've come with. Or it was great, Leila. Thank you so much for coming.
No worries. No worries. Nice to meet you all.
That was so good.
Yeah,
Really,
that was
really
amazing.
interesting.
That was huge.
Yeah, it was. But I felt like we covered loads of stuff, but also everything that she said, we were like, yep, we agree. We totally agree.
You've
Yeah.
just been like,
I
agree.
I
Agree.
really enjoyed it, and I think that you guys at home are going to really enjoy that as well.
oh, 100%.
Yeah.
I like the key messages as well, like we said, communication, but she was like, listen to women, which is clearly very important when it comes to sex, but also everything else. And then these pebble vibrators that she's like...
all of the people.
She said pebble. Was it just me that was like, do we mean a
an
rock.
actual
I
pebble.
think
Because
because
she
it
showed
looked
us,
like
didn't she?
a
It
pebble.
just
Yeah,
looked
I got
like
it when
a-
she pulled it up, but I
like
was
a
like,
pebble
what's
shape.
going on?
Yeah, it definitely
Yeah.
looked like a pebble. I thought
And
it
no
was great.
NHS vibrators.
And I think the big thing was that these conditions are treatable.
Oh, yeah.
They're common.
And
And
the treatments
treatable.
had such good, like, she
Yeah.
said something like 76%.
That was like the pebble vibrator,
yeah,
wasn't
yeah,
it?
yeah.
But she said even more following other
the numbers
treatments.
got so high.
But I feel like a lot of people think that they've just got a life sentence.
Yeah,
As
like,
soon
this is
as-
it.
Yeah, this is my bag. I can't have sex, therefore the end.
Yeah.
I think it's like clearly such a stigmatized area of
yeah.
medicine and health. So being able to talk about it with your GP or your gynaecologist or your friends is going to make a massive difference because, as you've said, they are treatable. So once you can express what's happening, you'll hopefully get a
I
much
feel
better
we are getting
lifestyle.
better at this, of people talking about things like sex that
Yeah.
used to be very, very taboo. So we just need to carry on the conversation.
Keep on going.
Yeah, absolutely.
So, a quick disclaimer. So, everything that we've discussed today are our own opinions and they are not affiliated with where we work and shouldn't be taken as personal medical advice.
Yeah, and hopefully you've enjoyed this episode as much as we have. And if you have, please do leave us a review wherever you get your podcasts.
It might seem like a little thing, but giving us a review pushes this out to as many people as possible. And we really just want to break down barriers, bust myths, and give out really good information.
Yeah, and we want this episode and the entire podcast to reach as many people as possible. So if you want to be a part of that ripple effect, then hit the like button now.
And make sure you're following us at Between Two Ovaries on all of our platforms and engaging with our content.
Thank you.
Thank you.